Emphysema is an obstructive respiratory disorder. This means that you have an easy time getting oxygen into your lungs, but you have a difficult time getting carbon dioxide out of your lungs. This results in your blood having plenty of oxygen within it, but you will have a high partial pressure of CO2 in your blood relative to oxygen, which is called hypercapnia. Another thing that happens during emphysema is the popping of your alveoli. They become distended and trap air within them until eventually the alveolar walls break down.
You're not getting out of here.
Emphysema is caused by the lack of elastin. Elastin is exactly what it sounds like, a protein that gives your lungs their elastic quality. Without elastin, you inspire, and then once you exhale, your lungs don't return to their normal shape afterwards. Another effect of the lack of elastin is that your alveoli lose their structural integrity. When your alveoli lose their structural integrity, when air goes to escape them, the opening collapses.
This represents a healthy alveoli. It gets blown up during inspiration, and then during expiration, it recoils to its original shape. With emphysema, the alveoli is like this bag. It gets filled with air during inspiration, and during expiration, it loses its recoil. It doesn't have recoil, so it stays the same shape and size.
Another thing that happens in emphysema is the popping of alveoli. When the alveoli pop, they leave behind empty spaces. They also decrease the available amount of surface area that can be used for gas exchange with oxygen and carbon dioxide.
To demonstrate what Taylor was saying, we have some balloons here in a baggie representing our alveoli. When they become over-distended, they pop. As you can see now, once the alveoli have popped, they leave pockets of air inside of the lungs.
Emphysema is caused by exposure to noxious stimuli such as smoking. The smoking toxins cause an inflammatory response in the lungs, which leads to the recruitment of neutrophils. These neutrophils create massive amounts of elastase, which breaks down elastin. This is why smoking is such a large risk factor for emphysema.
Emphysema impacts the respiratory system by causing difficulty with expiration. This is caused by the air that gets trapped in the lungs and also the diminished recoil of the alveoli. You can assess for this by auscultating the lungs. When you hear wheezing or diminished breath sounds, that can be an indicator of emphysema. I'm going to breathe in each time.
Okay, go ahead and turn around for me. Deep breath.
You can further assess this by using percussion. Hyperresonance may indicate emphysema. Can you turn around, please? Okay. noticed a little bit of hyperresonance, which is like a high-pitched, almost musical sound. Lastly, you can inspect the patient's thoracic cage. A longer and wider thoracic cage is called being barrel-chested, and that is an indication of emphysema. You'll want to make sure that you inspect laterally and interiorly so that you can see this. All right, can you face towards me with your arms at your side, please? Okay, thank you, and turn to the side for me. Great, so I've noticed that her chest is longer and wider, which is an indicator of barrel chest. Emphysema also impacts the cardiovascular system. It's caused by an increase in blood pressure, also called pulmonary hypertension. This is caused by pulmonary vasoconstriction. This means that the heart works harder to get blood to the lungs. This will cause the right side of the heart to become enlarged, also called cor pulmonale, and it's right-sided heart failure. You can assess this by looking for JVD, at capillary refill, and peripheral pitting edema. We check for JVD because the vasoconstriction of the lungs causes a backup of blood into the right side of the heart. This then causes blood to be backed up in the jugular vein, which is why we would check for JVD. We'll have the patient at a 30 to 45 degree angle with their head turned to the left, and we'll check their neck for pulsations or fluttering where the jugular vein is. Well, next we'll want to measure how far up it goes, because that can be an indicator of how severe the right-sided heart failure is.
You also want to assess for capillary refill because as the disease progresses, the right-sided heart failure can get worse, which causes decreased blood flow to the distal fingertips. Although they are able to get an adequate amount of oxygen, the weakened heart can't get blood to these areas. So you want to assess capillary refill by pinching the finger and seeing how fast it returns to its normal coloring. And it should be less than 2 seconds.
As emphysema progresses, the heart gets weaker. This can result in poor venous return, which can manifest as peripheral edema. In order to check for this, you want to take your patient's extremities and just lightly press down on the skin. The skin should return back to its normal position within 1 to 2 seconds. If you see a indent that stays, that's a good indication of edema. Typically, a patient with emphysema who's in respiratory distress will present with tripod breathing. Their hands will be on their knees, they will be breathing deep and fast through pursed lips. This will help them open their alveoli a little bit more so that they can actually breathe better.
Here's an example of how tripoded breathing may present in a patient with emphysema. Her hands will be on her knees to support herself getting a deep breath. As you can see, her lips are pursed, breathing deep and fast. And then you may also note the use of accessory muscles to help get a deeper breath. As you can see, her intercostal muscles and back muscles are doing extra work.
One thing that you do want to assess in a patient who has emphysema is their history. Typically, emphysema patients have an extensive history of smoking. This can present with tobacco-stained fingertips, lips, and teeth. Typically in emphysema, you're going to want to assess your patient's history. Along with that is in advanced stage emphysema, it usually takes a while to develop and get diagnosed by your physician. Normally your patients will be over the age of 65 and have an extensive history of smoking and COPD.